welcome Dr. Joe Jacobson, who comes to us from Harvard and Dana-Farber Institute. He is here for, we invited him for a very special reason, because he's one of the members of the International Advisory Committee for Rossy Cancer Network. And he's been instrumental in designing, with his colleagues from various cancer institutions in the US, Canada, and England, Great Britain, to establish the program, which we think is very important to improve the quality of cancer care at McGill, in all McGill hospitals. As Dr. Jacobson is a thoracic oncologist who is a professor of medicine at Harvard, and when even Dana-Farber Institute had problems in figuring out how to measure quality care, he's been hired by Dana-Farber as the quality improvement officer. Is that the proper title? Chief Quality Officer at Dana-Farber, and he's been instrumental there and at other bodies within the United States and internationally to figure out how to measure improvement of quality. So I think I don't need to say anything else. Obviously, he has many publications and is a member of a number of US bodies, cancer bodies such as ASCO, and helped to design standards of chemotherapy at ASCO, and had many other distinguished roles. He is here to speak on safety, quality of cancer care at the Dana-Farber Institute, and he will tell us how to measure all that. He will speak for about 30 plus minutes, and we would like to encourage you to ask questions since we have a distinguished speaker here, and he would be able, probably, very likely, I'm sure, to answer most of them. So we'll leave some time for discussion. So welcome, Dr. Joseph Jacobson.
Thank you. Thank you. It is good afternoon. It's a pleasure to be here this afternoon, and I'm honored to be here. Bon après midi à tous. Je suis très heureux d'être ici. Permettez-moi de vous remercier pour votre invitation aujourd'hui. That's my high school French revisited 40 years later. Thank you very much. And I will limit my talk to about 30 or 35 minutes, and then hopefully we will have plenty of time for discussion. I was invited to speak about safety and quality, but at least south of the border, we focus now very much on trying to define value of care. And as I've read through the Rossy material, it's clear that this is a shared need for the Rossy network as well. I want to go back to 1994 and talk about a sentinel event at the Dana-Farber, then describe it as I've witnessed it every day, and I've been at the Dana-Farber for almost 3 years. I want to just touch on two concepts and then talk about a framework that we've been working on at Dana-Farber that I think overlaps a lot with the Rossy Network's vision of the future of cancer care. So many of you may know the name Betsy Lehman. Betsy Lehman was a mother of 2 children and a renowned Boston Globe health columnist who developed metastatic breast cancer in her late 30s and was a patient at Dana-Farber from early on in her course. In 1994, she was involved in a phase 1 clinical trial receiving high-dose cyclophosphamide and was admitted on November 14th for the 3rd course. And as you can see, she received the wrong dose, and because of misreading of the protocol and many other things, instead of receiving a dose of 1,000 milligrams per meter squared daily for 4 days, a total dose of 4,000 milligrams per meter squared, she received that dose 4 days in a row. That dose was highly toxic to the heart, and she experienced sudden cardiac death on December 3rd, 1994, and it took actually 10 weeks for that dosing error to be discovered when a very junior research associate was entering data into the research database. The discovery was made. It was immediately announced, of course, to the family. It became public knowledge, and it was really, the Dana-Farber was pilloried in the local press and national press, and I suspect international press, for a long time after that. The Institute was placed on probation by the Joint Commission for Accreditation of Healthcare Organizations. So that is a history that we don't forget at the Dana-Farber, and I thought it might be useful to begin with that. When one does a root cause analysis and looks back to how that horrible outcome occurred, these are just some of the things that were discovered. There were almost no double checks needed at the time at this Dana-Farber, which was a research institute at the time. The orders had been entered on paper. We didn't have an electronic order entry system then, by a fellow with no supervision by an attending. The protocol language was really quite vague, and there were multiple versions circulating around the institute. The language around dosing was particularly ambiguous, and it was easy to see how the fellow could have made the error. There were no dosing guardrails built anywhere in the system, so there was no limit that could be ordered that would be blocked by a pharmacist, for example. The patient and family had concerns that they expressed on a daily basis, and those were largely ignored. And we really, at that time, had the most rudimentary mechanism for reporting dosing errors. So that really led to introspection at Dana-Farber required. I think it was an institution that was in extremis then. I was living in Boston, practicing across the street, and very aware of what was happening. So I would say that what happened to the Dana-Farber then really is that it viewed itself and adopted the habits of a high reliability organization. And there I'm using the definition by Weick and Sutcliffe, very good book if you haven't read it, Managing the Unexpected, talks about how high reliability organizations achieve the results they do. And the Dana-Farber really went through a series of steps that in hindsight mimicked those of other organizations. So there was, of course, immediate change in senior leadership. The physician in charge at Dana-Farber stepped down. We recruited a chief operating officer, Jim Conway, who was well known as a leader in patient safety, and he spent a long time converting the organization to one that focused intensely on safety, built out the patient safety office. Standardization of chemotherapy preparation and administration became routine, and double checks were built at multiple steps along the way. The reporting system for safety events was ramped up with a focus on near misses rather than actual events. We moved to an electronic order entry system within a year, and that system is still in place. It was, after that event, no longer possible for a fellow to order chemotherapy. And the clinical trials office, which is enormous at the Dana-Farber, there were hundreds of clinical trials open at that time, really began standardizing what they do, making sure that there was transparency and inclusiveness so that pharmacists and nurses throughout the organization would be able to have, the very clear definition of the protocol in hand. And the Dana-Farber created an early patient family advisory council, which I think is emulated around the country. It's a very large, powerful organization at the Dana-Farber that literally helped us design our new cancer tower, our patient tower. They sit on every important committee and team within the organization, and they have a very strong voice within the organization. So Dana-Farber in 1994, 1995, on the left side of the screen, was really a research institute in patient care. I think was viewed by many as a secondary, of secondary importance. That certainly changed. The Dana-Farber then had a 40-bed inpatient unit, and what was said about it at the time was, thank goodness it was near two very good hospitals. not itself providing the kind of care that you would expect for patients who were probably the sickest in the city. And a small ambulatory practice was really sandwiched between research laboratories. Today, the Dana-Farber no longer has an inpatient unit, and our patients are admitted to the Brigham and Women's Hospital across Binney Street. We have 130 of our own beds and commonly fill 160 or 170 beds at the Brigham. So that old inpatient unit is now gone. When you combine us with the Brigham and Women's Hospital, we're the largest single provider of inpatient care with the second largest bone marrow transplant program in the country. And the ambulatory care tower, which I just alluded to, is really quite spectacular, designed by patients so that I think it is as patient-centered as can be. We've grown about 7-fold in volume with about 18,000 new patient visits per year and over 700 clinical trials open as of last year. So it just gives you a sense of who we are. So I'm going to walk through two concepts really quickly as I keep an eye on time, and that is, what does it mean to be an innovator in cancer care? I provide a definition of innovation at the bottom, borrowed from Partners Healthcare, which is the Partners Healthcare is the largest employer in Massachusetts, and it is a conglomeration of 5 or 6 or 7, it's growing so quickly one loses track, hospital systems across the state. We're affiliated but not part of it. But this is Partners' definition of innovation, which I won't read, but the important thing is to distinguish it from improvement. And when I moved to the Dana-Farber 3 years ago, I wondered, I knew the Dana-Farber was a world leader in innovation. But as I looked across these 5 domains, it was really clear that we were innovators in basic science, extraordinarily so, translational research, clinical trials, a very large outcomes research organization. But really, I don't think we had then or have yet become real innovators in cancer care delivery in a way that I think the Rossy Cancer Network is also striving to become. And when you read the vision of the Rossy Cancer Network, it is in fact to be innovators in cancer care delivery. That's what I think we need to achieve. So that's concept number 1. And number 2 is also part, I think, of the Rossy Network, and that is moving beyond quality and safety to value. And here I've borrowed Michael Porter's definition from Harvard Business School. He wrote an extraordinary little perspective piece 3 years ago in the New England Journal with 2 very good appendices online associated with it, much better than his 500-page book. So if you haven't read these, it's worth reading. As people do, he defines value as quality over cost, but importantly, outcomes, the measurement of outcomes achieved over the full set of costs. We're very good at measuring processes of care. They're easy to measure. They're convenient. They're not controversial in general. But Michael Porter really makes the argument that one needs to look at outcomes and let's see if I can go backwards. And really, the outcomes is defined by the patient. And Porter talks about 3 outcomes, 3 tiers of outcomes. And tier 2 is the one that focuses on patient-centeredness, both the utilities of care, the patient experience of that care, and then the disutilities of care. What things happen during that episode that were difficult? Long waiting times, fears about the care that was being delivered, communication, et cetera. So value is defined around the patient. In the United States, we focus on inputs. We like to think that we provide good care because we spend, I think, almost twice as much as you do on healthcare in Canada, but in fact, it's important that we focus on the outputs, on the outcomes. And then it's important to measure the cost of care really across that entire episode so that you're collecting it importantly. So those are 2 concepts I just wanted to make. And then I want to spend a little bit of time talking about the framework that we've put in place around quality and value at Dana-Farber. And I hope that this will become self-explanatory. But in the very center, of this is the nucleus that we think is absolutely essential to have an effective cancer program. So there has to be buy-in from the most senior leaders in the organization and the trustees. And at Dana-Farber, we've been very lucky to have an enlightened CEO and trustees, many of whom were still part of the organization in 1994 when we had our Sentinel event. And one worries when they retire that we could lose some of that leadership. But leadership is vital. The leadership has to believe that the clinical enterprise is vital. The infrastructure, of course, is essential. And more we rely on an information system. We've had a Partners homegrown system, which we call the longitudinal medical record. Partners is spending, I think, something like $1.8 billion in the next 4 years to convert to Epic, like 10 or 20% of American hospitals. But infrastructure is vital. If you don't have it, you will be building a system that will not be able to sustain itself. There has to be governance in the way that, again, the Rossy network is defining. You can't have multiple different improvement projects going on across an organization that are either duplicative or, in fact, are resulting in outcomes that may compete or with one another. So governance is vital, and having an aligned culture is essential. If the entire organization isn't committed to the principles around improvement, around measurement, you won't get anywhere. So that's the center. You get nowhere without this, but these are the 6 domains that we think are particularly important. Safety I've already dwelt on, and I won't go further, but it has to be embedded into the organization, and moving your organization to high reliability using principles from the Institute for Healthcare Improvement is absolutely essential. I'm a huge believer that if you can't communicate what you're doing, if clinicians are not communicating thoughtfully and carefully, if documentation isn't synoptic, if it isn't structured, if you're not engaging all members of a multidisciplinary team and documenting that encounter carefully, you're probably missing a key step. When patients are polled, they frequently will report that one of their greatest concerns is that their clinicians are not communicating. So we'll come back to it, but as you're about to roll out in pathology, synoptic reporting, we think is vital across all the cancer services. Measurement, one of my mentors from Intermountain Health, Brent James, said over and over again when I trained with him that you can only manage what you measure. It's absolutely essential that the measurement program be built out, that it be built out thoughtfully, that there's a shared understanding of what needs to be measured, that there's a dashboard or scorecard that collectively the organization feels includes measures that are important to the whole organization. So I'll come back with some examples. Once you've measured, you can begin improving. And to me, that there are 2 components to improvement. One is that there's a need to be sure that there's sufficient training for those involved in clinical care to understand what it means to improve care. And then there has to be a structure in place so that projects are being overseen carefully, and that's where the governance fits in. Again, training at Intermountain, I'm committed to principles around standardization. There's so much unwarranted variation in care. If you go to the Dartmouth Atlas in the United States, you will be overwhelmed by how care varies across the state and the states and how much unwarranted variation there is. So I'll come back to this. And I won't talk about self-reflection further, but I think it's a vital piece of care improvement that we often overlook, and that is, bringing clinicians together on a regular basis to share opportunities for improvement in a protected environment that's blame-free, where everyone feels comfortable that when they leave, they've contributed something and they've not felt personally denigrated. I don't think we do this barely enough, and my organization is really still very early on in the journey that needs that we need to continue along. This is our department of quality and safety at Dana-Farber. It has about 26 members, and I show it to you just to show that I seem to do this poorly, that it's broken into two separate components. We have a Center for Patient Safety and a newly minted Center for Cancer Quality and Innovation. And on the left-hand side of this diagram is really where the work of safety is done. So our Director of Patient Safety lives here, overseeing our hospital epidemiologists. We have responsibility for risk management over here, for the medical staff office, for patient and family relations. All complaints feed through here. And that center is linked very tightly to this new emerging Center for Cancer Quality and Innovation. At the moment, we have 3 directors there, one focused on large clinical projects, another overseen by an industrial engineer, oversees the operational projects largely, and our analytics. And we've just recently brought in a member of our finance department who has a direct line report to our CFO, who's called our Director of Value, but she lives actually within the quality department, which we think is vital and shares the analytic resources. We will probably bring in a 4th director with expertise in informatics and measurement, and we think that will build out our capability. But that's our structure, and we have created a quality innovation leadership team that began meeting last March. That's a group largely of clinicians with a couple administrators, and we're hoping they will also help with governance as we move forward. So these are, I don't think if we stay within time frame, I can walk through all of these projects, but I'll mention a few along the way that I think may have relevance to the RCN. Starting in the center, we have been working on aligning culture, and we started at the top of the organization and have partnered with Harvard Business School to hold 2 separate retreats. Richard Boehmer, I think, is the only physician at Harvard Business School who has been part of both of these. The first brought our CEO and CFO and other senior leaders together and clinicians to really define value for us, which was an important step. The second one, which we held last spring, brought sort of the middle of the organization, middle leaders, both clinical and administrative, to really, in my mind, talk about what care design is all about, cancer care design. And we're now thinking about how we push this much deeper into the organization with the goal eventually of getting to 100% participation. So everyone within the organization will feel that they understand the importance of quality and safety and defining our value. So let me talk first about safety. I think it's what we do best. It's a legacy that Jim Conway left when he retired a few years ago. But our focus this year is on what we think is an emerging threat, and that is around the rapid emergence into our treatment armamentarium of oral chemotherapeutic agents. All the safety systems that we've put into place over the last couple decades depend on patients feeding through an infusion clinic where we have highly trained oncology nurses and pharmacists, and they make sure that the drugs are administered safely. I think there are now 38 FDA-approved oral chemotherapeutic agents with scores on the launching pad, well, dozens, maybe not scores, that we will likely face in the years to come. The great news is that these are effective agents, but they also turn out to have unique toxicity. So ASCO and the Oncology Nursing Society came together over the last year to draft a set of standards. The first set was drafted and published in 2008 or 2009. This focuses on the particular challenges of oral chemotherapy. So we've committed organizationally to implement all of these standards across our network, our center and associated community sites this year. I've talked within this group has talked a lot about documentation and communication, and Dr. Roy has been working on synoptic reporting for pathology. We've been working to try to create a standardized synoptic chemotherapy treatment plan. This comes from ASCO. To date, or the way that chemotherapy is ordered, many of you may appreciate, is sort of behind a black curtain. There's very little transfer of information to non-medical oncologists about how the decision was reached to use chemotherapy, what the indication was, the doses, et cetera. So we have taken on the challenge of trying to come up with a standardized document. We've built this into our old electronic health record, and we got off to a slow start. This is what the document looks like. It is standardized, it is synoptic, it includes the stage, things that, the kind of things that one would expect, the diagnosis stage, the indication for treatment, the regimen's name, EP5050, but actually the drugs and doses and expected duration, side effects, any other features like concurrent radiation, details that might be relevant, and then the performance status. So this is a step for us towards standardizing care, something that you may want to think about moving forward. This is the way that I show this slide only because this is the way we like to look at data at Dana-Farber, and this is called a statistical process control chart. It's a convenient way of looking at data over time because it shows you both upper and lower control limits. It lets you know what your process looks like. So when we rolled out this particular program, the chemotherapy treatment plans, we went 5 or 6 months and weren't particularly satisfied with the overall rate of compliance of about 64%. We then thought it was time to begin sharing the data with our disease center leaders in an unblinded fashion, and that, as you can see, led to a change that's been sustained. Our goal is, of course, to get to 100%, but this is a program, and this is the way that we like to see data reported. I want to mention the COPI program because it is now available in Canada, and it's something that the RCN may think about. ASCO is the American Society of Clinical Oncology. It is, I think, the largest cancer-focused physician organization with about 35,000 members. ASCO created something which we call COPI, the Quality Oncology Practice Initiative, and launched it for all members in 2006. It's a free service, and in essence, it's a tool for collecting process measures. There are now over 100 process measures that you can collect within ASCO, ASCO's COPI program. This is a program that's really targeted more for community practices. It enables practices to review charts, submit data, and have that data benchmarked against other COPI participants. I think real benefit is to see how you compare, and also to begin working together. It's the way the COPI program is designed, data can be shared in a way that you can keep it within a collaborative network. So if RCN chose to do this, COPI would be able to share the RCN-specific data. The program has grown dramatically over the last 6 or 7 years. There are now over 900 practices in 14 different countries. We've expanded this to be a fellowship program, and this kind of gives you a sense of the kind of data that, or the growth of the program. I'll show you just one measure. We have 3, at the time, this was last year, we had 3 satellite clinics outside of Boston, Milford, Londonderry, and South Shore. We piloted the COPI program at the Milford location, and one of our measures was, one of the COPI measures is there documentation of the chemotherapy treatment plan somewhere within the record. So what we did was bring the chemotherapy treatment plan that I just showed you to this Milford site. That was our intervention. We were quickly able to markedly increase their COPI scores. And then as we moved across network. You know, we didn't have to go back to square one. We had a tool that was already tested, and we're able to implement that at the other 2 locations. So that's how COPI might be useful for you. There's a certification program now associated with COPI. There's a charge for it based on the size of your program. It has 3 components, and it would be available within the RCN. It requires actually achieving a certain score on something like 40 or 45 COPI process measures. If a practice manages to do that, they can apply for certification. They then have to demonstrate by providing documentation that they have safe chemotherapy administration practices. And once they've done that, then they're submitted to a Joint Commission-like on-site audit. And if they pass, they're awarded 3 years of certification. Our satellites went through this last year and passed, and there are about approaching 200 practices around the US that are now COPI certified, something to think about. We spend a lot of time focusing on utilization. We looked at our high-cost drugs. You may probably already do this, but you know, drugs like cetuximab, bevacizumab, granulocyte colony-stimulating factor, use in the palliative setting, and have shown that we don't have much opportunity for improvement. We've looked a lot recently at end-of-life care. I'll show you one slide. And then we look at some of our high-cost radiation techniques like intensity-modulated radiation therapy, stereotactic radiation, to be sure that we're using them judiciously to manage costs, and for us in Massachusetts to prove that the Dana-Farber can be judicious in using these very expensive technologies. Let me walk through just a little bit of data on end-of-life care. If you go to the Dartmouth Atlas and look at Medicare data across the US, you'll find that for cancer patients, we tend to offer far too much therapy and enroll patients in hospice far too little. So we were interested last year in what our commercial patient population might look like, our younger patients. So we shared data with the largest insurer in Massachusetts. We supplied to them the unique identifiers for patients who had died within our care using specific criteria. We used the 6 National Quality Forum measures that Craig Earle at Cancer Care Ontario had created. And this is the kind of data that we got back to show us what sort of opportunity we had, and also to know how much of that care we were providing at the Dana-Farber in red versus what was being provided outside. And as you can see, these are numbers that we're not at all proud of. Chemotherapy in the last 2 weeks of life, a measure of overuse, over 10%. Hospice enrollment, just barely over 50%, and of those patients, almost a fifth were enrolled for less than 3 days, certainly not enough time to benefit from hospice care. Emergency room visits were common, hospitalizations were common, and nearly 3 in 10 patients died in the hospital, whereas if you poll the patients, they will tell you they don't want to die in the hospital. We're extending this analysis this year to look at radiation in the last month of life, surgery in the last month of life, blood transfusions in the last month of life. And we're also finding lots of variation across our disease centers, and our heme malignancy group tends to be very heavy users of end-of-life services, even in the palliative setting. So an opportunity. Based on that, we also decided to try to define what might be a potentially avoidable oncology admission here, focusing on medical oncology, and look just at our GI disease group because they had a very high rate of hospitalization. And the important number is right in the middle, and that is that what we found in this retrospective analysis is that 1 out of 5 hospitalizations seem to be avoidable. And the group of patients who were being admitted were those who were either by chart review refractory to therapy or had a very poor performance status. And in fact, when you look at their outcome 90 days after that admission, either they had died within 90 days or had quickly been readmitted. So we've now felt we've replicated this data prospectively, and we're now planning an intervention. So we're moving around that diagram that I showed you before and are working with our palliative care service to get earlier engagement in palliative care for this group. I want to talk a little bit about training. When I came to Dana-Farber almost 3 years ago, I was already co-leading a process improvement training program at Partners Healthcare, which I've already mentioned. This is based on the Intermountain model. It's an experiential program, so all participants have to do a quality improvement project over the course of 5 months. We offer them a series of basic lectures, and then we offer them the tools needed to get through a project. And then they come back on the final day of their project to present in front of their peers. And because these are all, you know, type A Harvard faculty members, everyone tries to outdo each other, and we get very high-level presentations. So when I created this slide, and still true, we've trained about 250 people across partners. When I moved to the Dana-Farber, I was able to bring Dana-Farber teams in. So we have 12 teams through training, another 9 teams that are currently training as we are ramping up this effort. At Dana-Farber, we also have a separate improvement program that's focused on the operational staff, and we've now gone through 2 cycles of that as well. I had deleted a slide that showed you sort of the projects that, the list of projects that we've done so far. They're very basic. We focus more on the skills than on the projects right now, although, you know, there's more and more pressure to make sure that the projects are aligned with the organization. This is where I'm going to stop to talk about the pathways work that we're now undertaking at Dana-Farber and across our network. And I'll use a definition that we've been sort of crafting, and I know that you're working on pathways and yours may be aligned or different, but we think first of all, a pathway has to be multidisciplinary. It can't be just medical oncology or surgery, but it has to bring together all the clinicians that are involved in the care of that patient. It is about creating a structured process that takes existing evidence or consensus, because the evidence often doesn't get us far enough, and translates that into a detailed care plan. One then defines key process steps around which you can identify key process indicators and expected timelines that one can measure. And then the important point is that it standardizes work for that specific clinical problem, but it doesn't create a cookbook approach. It really encourages physicians to vary from the pathway, but the important thing is that clinicians have to be able to document in a structured way why they chose not to follow the pathway. There has to be a mechanism for tracking adherence, and the document has to be living if it's going to be valuable. So there has to be structured, scheduled updating of that pathway, or it becomes out of date. This is a very simple one, looking at management of patients with testis cancer, but if you follow it, which you can't do because I'm about to click the next screen, it will walk you through the various branch points, and there are multiple key process indicators that can be built into this system so that you know that patients are tracking appropriately. This is the pathways model that we, you know, writ large. It begins on the left-hand side. There has to, and this is really borrowed from the Intermountain model, there has to be a pathways management system. So we have a very senior pathways steering committee, and then we have an operational committee. We've just hired our medical director of clinical pathways. But in essence, that group I'm not good with buttons. That group, there are only 3, so you can imagine how challenged I am with technology. Each of our disease centers has created a pathways development panel, and we've hired what we call clinical pathway architects, CPAs, associated with each of these. They build the pathways, we begin testing them with patients, and then the goal is that, and we're still building this, that we will collect data, first of all, and most importantly, was there adherence to the pathway, and if there wasn't, why not? And then we hope to bring in disease characteristics, comorbidities, psychosocial factors, importantly, patient preferences when that's important, bringing in outcomes, particularly patient-reported outcomes, and then that leads to the feedback loop so that our our pathways are continuously improving. This is, I think, my final content slide. So this is where we think pathways will fit in for standardization. It's a tool for reducing unwarranted variation that does not restrict clinical decision-making, preserves the craft of medicine. We need to contain it, but we don't want to eliminate it. It needs to engage all stakeholders, clinicians, for example, for us, not just from our ivory tower academic center, but from our satellites. So we engage our clinicians from the satellites in the development of these. It has to, and most importantly, I think in 2013, facilitate rapid incorporation of new information. So we have a large genomics program. We think pathways will let us incorporate the rapidly changing landscape of genomic medicine and the complexity of medicine, which will change so quickly into the management of our patients. And then, even though the Dana-Farber has 700 clinical trials open, only 10% of our patients at any moment are on an active treatment clinical trial because of the specificity of those trials. So when I teach this, when I do my song and dance, it's about letting us learn from the other 90% of patients. When I brought this to our Patient Family Advisory Council, first of all, they were shocked that we didn't already do this. They were, they couldn't believe it, but then they embraced it very quickly. So this is the paradigm, and when it's working, if it's working, we hope that it is in motion all the time. So that leaves time for questions, but a rapid kind of description of our current quality and value program. So thank you.
Jacobson, for this wonderful, impressive, and timely presentation, and we hope to benefit from your continuing advice at the Rossy Institution hospitals.
Yes.
Questions?
And you're supposed to use the microphone when you come up. That's my reminder.
Eduardo.
Your last slide, in fact, I was going to pose the question of how can you imagine the tremendous source of variation, which is an institution which is in the vanguard of running so many clinical trials.
Yes.
And yet you gave the answer to the question I was going to ask. So actually, 10% of those patients in which you cannot control the variation in care, your pathways perhaps would have escape routes there because of the need for being adapted to the requirements of the clinical trial.
Yes.
This is a minority of your patients, right?
Yes.
The vast majority you can standardize and have those algorithms and pathways rather.
Yes, that's right. So the question was, if a center that's focused on research with so many hundreds of clinical trials, how could you possibly build a pathway system in? And the answer is that, as you all know, clinical trials are so specified that patients will often not meet entry criteria because of a minor abnormality in laboratory tests or some prior treatment excluded them from the current trial. So we really hope that this becomes a learning system for us that enables us to, in a comparative effectiveness kind of approach, learn from this patient population. And we hope that it's a way of engaging our clinicians in a different way. We've done it slowly. I brought it to our clinicians in small bits over the course of 2 years. So that when our medical director of clinical pathways presented to our cantankerous medical oncology faculty 8 days ago, everyone nodded that they knew we're going to do clinical pathways. So it's been a slow motion process of acceptance. Yes. Yes. May not be on.
As a surgeon, I'm part of a specialty that's very specialized in generating adverse events, patient dissatisfaction, bounce backs to the ER, rehospitalizations, all the things that are associated with whatever your definition of quality is, lesser than that. And so after a lot of debate and ego-centered interesting moments within the surgical societies, about a decade ago, people started saying there is a problem and let's start doing something about it. And they did start doing things that fall under the broad category of surgical process improvement tools, SPITs. And the most known one is the checklist, the preoperative checklist, the timeout, this, that, and the other. What I'm noticing is that in the last year to 2 years, there's starting to emerge growing dissatisfaction, if you want, or pushback, because people are saying, yes, there are near misses, never events, and all those things, but we have to do about 1.5 million timeouts and checklists to perhaps save one near miss. So what I'm wondering is, in your institution, and you're coming at it from a very broad perspective, covering medicine, surgery, end-of-life care, screening, and everything. Have you sensed that pushback, or the concern that how many of these do we have to do to actually save a life or
Yes.
avoid a near miss or a never event?
Right. So a complicated series of questions for which I have no good answers. I've had the pleasure of getting to work closely with Atul Gawande in the last couple of years, who's now started a healthcare delivery institute, which he calls Ariadne Laboratories. And so I've learned some of his frustrations about the surgical checklist. And for those who didn't read it, there was a paper in the New England Journal last year in which he brought a group of operating room staff together to simulate accident or errors or adverse events in the operating room, bleeding, et cetera. And the paper was published in the New England Journal, but you didn't have to read very far to see who participated. And no surgeons showed up to participate in a surgical OR simulation study. So I understand the challenges of working with surgeons, and I don't think the answer is going to be an endless series of checklists for sure. The hope for us with creating pathways, at least which we're going to test at the Dana-Farber this year, is that they will be built enough into workflow that the medical oncologists won't rebel. So if you build systems that are unaligned with normal workflow, there will be rebellion, and you may get people to do it by force of will or by other way, by incentivizing them or paying them to do it for a while. But if it really makes their work more difficult, it's not going to be sustainable. The harder question is, how much do you invest in systems to prevent a single adverse event? If you view this from the standpoint of a high reliability organization, you're willing to go to great lengths to do that. And when I bounced around in a twin-engine propeller plane coming here yesterday in the storm, I was glad that I was flying with an organization that was high reliability. It was a bit reassuring, but it's from the old industrial literature, it said that it takes, for every severe event there are 29 injuries, and there are 300 errors, 300 events. So there are 300 misses, 29 or 30 accidents with some injury, and then one severe one. So that I kind of keep that in the back of my mind when I think about these programs, But you're right. At some point, you have to do. Everyone has to do some sort of math. How much effort do we go to prevent a wrong-sided surgery, for example? But no answer.
I'm not going to ask a surgical question, though. So you're talking about resistance and which with every new technology, every new innovation you're going to get. I would like to have your impression of where you found the roadblocks during your processes and how you went ahead and tried to eliminate or circumvent them or prevent them.
Yes. I'll borrow a quote from Bill Berry. Bill Berry is the chief science officer in Otogo Ande's laboratory, and Bill is the on-the-ground guy. He calls himself a reformed cardiac surgeon, and he's been spending the last year in South Carolina spreading the OR checklist. And what he says is you have to touch each individual if you want your project to succeed. So you have to build that army, but you have to touch everyone if you really want to get buy-in. And I think that's true. At the Dana-Farber, my challenge was somewhat different because of the mindset of everyone. Harvard Medical School is 2 blocks away. Everyone wants to get promoted. Everyone wants to get their clinical trial published, or they want to come out of the laboratory for 4 hours a week and provide their clinical care so they hold on to their clinical privileges. And that group, frankly, doesn't care whether care is efficient or particularly safe, because they're going to practice heroic thoroughness, as Don Berwick says, to make sure that in those 4 hours no harm comes to their patients. And if they go back and finish their work in the lab the next day, it's okay. So for me, the biggest challenge has been overcoming those who don't view healthcare as their primary, the thing that gets them up in the morning. But it is, I think, the need to touch everyone who you're trying to influence if you want to be successful. You can't delegate it very far, or you'll lose.
I'm curious to know about the clinical pathway, a twofold question.
Yes.
The first one is, how do you get people together, or did you find any, do you have any advice for us about this? And the other part is a bit aligned with what Dr. Gottlieb said. I wonder if there's some, when you have clinical pathway, you want people to adhere to it and follow it. Do you have some idea about what might be some incentive?
I'm struggling on that word, incentive, because it was your last word. The way that we did this at the Dana-Farber, for me, I'm a thoracic medical oncologist. At the Dana-Farber, we're so subspecialized, I'm actually left upper lobe. But only kidding. We brought our medical oncologists together and identified a junior faculty member to be what we call our CPA, or clinical pathways architect, met with them several times to talk to them about the process, and then actually sat down to try to create a very simple pathway for stage 4 non-small cell lung cancer, and found that we had 6 or 7 different opinions among the 12 people in the room about what the starting regimen would be. And we realized that we probably didn't need that there's actually not a strong evidence that steers you to one or the other. And in the second meeting, or the third meeting, we talked about maybe picking just one, which was really, that was the intellectual leap, that it's okay to pick one, because you don't have to pick it for your patient, that you can vary from it. And so we started that work in thoracic because I guess I knew I would have the most buy-in. They were friends and colleagues. And now we've begun spreading it to the next disease center, picking one in which we know we have, we have a lot of support. And it's going to be an uphill battle. The incentive for me, I saw, was this group seemed to like getting together after they got over the first hurdle. The idea that you might preemptively decide how to treat a certain condition is novel, but then it becomes a little bit contagious and you want to move on. So, how you bring in other stakeholders, radiation oncologists and surgical oncologists, will vary. We could build this, into an real incentive model, but we haven't done that yet. But it turns out to be something that physicians initially think is anathema, and then they find it's really not so crazy, and actually, you get to demonstrate your knowledge of the arcane literature in front of your peers, and that is fun for some of our academicians.
Indeed fascinating. Now, all of this is mounted on an academic structure, right? You're talking about Harvard University, and you have your medical students, both undergraduate, postgraduate medical education, which is more or less the same situation we have at the Rossy Cancer Network. Now, with all the vagaries of having to teach at the same time you do all of this, and having to do research and mount all of it, can you elaborate on scenarios that you have there for research, all the academic setting that
Yes.
would be required?
Right. So it's hugely challenging. There had only been 2 opportunities for academic advancement at Harvard Medical School. One was the classical research track, and the second was around education. And the education one really meant writing and writing and writing and traveling around the world to become internationally renowned. Recently, the medical school created an innovation pathway, and what I'm trying to do now is, and I mentioned before that I had been able to bring together a group of clinicians that we call the Quality Innovation Leadership Team. I've been looking for, late 30s, early 40-year-old clinicians who didn't fit in either of those classic tracks and who are looking for a new way to be promoted and who may be able to identify that there is value in making care more efficient, more predictable, with less unwarranted variation. So again, for me, I spent a year walking the hallways of Dana-Farber looking for the right potential candidates, getting turned down by probably 3 out of every 4 who couldn't see a vision beyond I'm a researcher or I'm an educator. So it's been very challenging, and for us now, it's looking for ways of funding them going forward. The institution is willing to protect little slivers of time, but we need more time protected if they're going to be effective in the long term.
So Joe, a question maybe building a little bit on Adrien and Walter's question. You described this very nice process of getting the clinical pathway established and taking bigger or larger parts of it. For this network, I mean, what would your guidance be on, is that a possible project for this network? So we have people in different institutions, maybe people who are keen to take leadership in a specific disease entity. How do we get the bridges built? What kind of infrastructure is required? Do you need kind of ClinEpi support to help them extract from the literature? Think a bit out loud for us about, in a multi-institutional world like this, could we do this and what would it take?
Yes. Thank you, Terry. I think you would need to identify, first of all, someone who has a core belief in this sort of standardized approach to care, who would lead the effort. So someone who has enough protected time to beat the bushes and look for those who would be willing to participate. So a leader. I think you clearly would need project management for this to be successful, and someone who's able to bring together groups from different organizations, at a convenient time, or to do this virtually, to bring groups together virtually, which which is how we've been working with our satellites. We haven't found it necessary to have people do the literature reviews because our clinicians have that knowledge, and I imagine that you won't need that as well. So it's finding the right group of clinicians who are interested in doing this, providing them project management support, and then as you're building out your IT structure, I think being certain that you have the capability within the system to be able to track key process indicators and to ultimately be able to link those to relevant outcomes, proximate and more distal outcomes, patient-reported outcomes, hospitalizations, ED visits, toxicity of therapy, if you can collect it, all those things. Those are the basic ingredients, but it is time-consuming and iterative, and I worry that I'm still worried about sustaining the project at the Dana-Farber, so that you would have to, as you do your project planning, figure out how you would sustain it going forward.
Hi. From your findings of end-of-life care, have you changed practice as far as early integration and early referral to palliative care?
Yes, that's a great question. So we're trying different experiments around the campus, but the one that interests me most right now is our GI cancer group, which has defined this potentially avoidable hospitalization. And we've just this week gotten funding to hire a part-time RN who will be working with the practitioners and with the patients in that disease center, and with a newly recruited a palliative care physician who will be working mostly in our ambulatory center to identify those patients. So this work is being led by one of our health services researchers, Deb Schrag, so it's being done in a rigorous way so that we will learn from the intervention. But there's every reason to believe that that early integration of palliative care will make a big difference. Jennifer Temmel across town at the Massachusetts General Hospital, as you know, published a couple years ago in the New England Journal of Medicine that if you engage palliative care in the care of patients with metastatic non-small cell lung cancer, at the very beginning, you will, first of all, extend their life, which has not been replicated yet, but certainly you will improve the quality of their life and reduce the utilization of those high-cost resources and awful ones like being hospitalized or visiting emergency rooms. So we have two of our small projects from the course that I mentioned right now are focusing on end-of-life care, one trying to get advanced directives earlier, and another looking in a satellite of how to engage patients in a palliative care pathway that they've created sooner. So we have to do this, and it's, I think medical oncologists are embarrassed when we show these kind of data.
So Dale Jacobs, who just asked that question,
Yes.
is infirmier pivot, which is, and if she follows patients from
Yes.
active care straight to
Yes.
palliative care, so we have started this.
Yes. So I should learn from you.
We have perhaps a couple more questions only. Padma?
Yes.
I was actually interested by your value measure.
Yes.
And I was hoping that, I guess Rossy Cancer Network has more reason to be value focused given perhaps a smaller purse than Dana-Farber. I was wondering if you could say anything about priority setting along the lines of what we could focus on as, initially if you have less money.
Yes, so I understand the budget is tighter than ours. We feel great pressure at the Dana-Farber because we know that any service that we provide will be at a higher cost than our competitors because we're supporting a large research infrastructure. And in Massachusetts, where healthcare reform began a few years ago, we were the first state to require universal insurance. We are under great pressure. Yes, that's right. We call it Romney Care in Massachusetts. But insurers in Massachusetts have actually created low-cost products that exclude us from their care. So we are really battling to stay in the marketplace. So it's very serious for us. And there are also tiering products that, even though they don't actually exclude us from the market, they functionally exclude us. So we feel this in spades and worry about our future. So to that extent, we are in the same boat as you. When I would look at those high-cost services or products, so high-cost drug use, for example. I don't know how carefully you're looking at, the high-cost biologics, the new oral targeted agents, which at least south of the border cost a fortune, $7,000 to $10,000 a month. And I would look at things like hospitalizations and emergency room visits as easy and early targets. In radiation oncology, again, I would look at intensity modulated radiation therapy. We did a project with Blue Cross Blue Shield of Massachusetts, bringing all radiation oncologists together and getting them to agree on when IMRT should be used all the time, which is head and neck, prostate, and pediatric cancers, and then criteria for when you might bring it in for other cancers, created an internal peer approval network, and we've been able to reduce IMRT use in Massachusetts by 30%, and that's a manuscript that Blue Cross Blue Shield is preparing with us right now. So that's an example. You could look at radiation therapy as well in the palliative setting and look at the number of fractions you're using for palliative bone radiation therapy. We probably need far fewer fractions than we're providing now. Those are, easy early targets that you might consider.
So Dr. Jacobson has another obligation very soon, 7 o'clock, I think, so we should, release him to the Montreal weather again.
Yes.
So thank you very much for coming.
It's really my pleasure. Thank you.